Michael's a board certified in internal medicine, board certified in hospice and palliative medicine. He is a fellow of the American Academy of Hospice and Palliative Medicine and the founder of Resolution Care Network. I think your model is not only, it was ahead of its time, but now it's probably the most pressing and relevant model out there. So we want to spend a little time talking about that. Thank you for taking the time to share some of your experience. I appreciate it.
Yeah, of course. I mean, it's a strange tailwind for an organization that's been trying to grow for a long time. It's sobering to acknowledge 16,000 deaths in the US and all the impact it's had all over the world. And to see that the work that we're doing and have been doing for 5 years, its relevance is a sobering and humbling moment for us as an organization. And you're right. I mean, for 5 years, we've been delivering palliative care through video conferencing technology to rural communities in collaboration with health plans and collaboration with community-based providers of care. And for the last 5 years, I've told people, wow, telemedicine, wow, it kind of is better than real life. And the first time they heard that, they pretty much usually think that's fascinating and provocative. But then the second time they've heard it, they roll their eyes like, I don't know, there that Fratkin goes again. But about 3 weeks ago, that certainly changed. And people recognize that it's what they've got to do to protect the people they're caring for and to protect their staff. And they're discovering really quickly that it's true. In so many ways, it's better than real life.
What kind of a mix of in-person or purely remote services you offer, just to ground the conversation a bit?
Well, just imagine, like the thing that I tell the people we enroll is that we don't take care of any patients. We only take care of people. And we do that with a team, a comprehensive, fully composed, robust palliative care team that includes a doctor, nurse, a social worker, a chaplain, community health worker, patient care coordinator. That whole team wraps around the person under our care, not from a disease-centered perspective, but from a human-centered perspective, and does a lot of work collaborating and integrating the whole suite of healthcare delivery that the person has. So the disease-directed care is optimized, as well as the person-centered care, support, communication, goals of care, symptom control, all the things that make palliative care valuable. For 5 years, have provided that in a combination, a hybrid model of in-home, in-person care, knock on the door, walk in, sit on the couch, deal with the dog, have some cookies, that whole thing, in addition to video conferencing encounters. And I'll tell you that a week and a half ago, Monday before last, we had about 45% of everything that we did through video conferencing. By Wednesday of that week, it was 100%.
So, Michael, you wrote a blog post for CAPC. Most clinicians that are now forced into immediately transition to telemedicine, this seems sort of like, look, it's what we have to do right now. In your blog post, you said it's first things, don't think of this modality as a compromise. And you said at the beginning of this conversation, it's better. So expand upon that a little bit for folks that are newer to it and are thinking of this as a compromise.
There's two major dimensions in order to get you into the clinic environment. You walk into the door and you're greeted by a waiting room, usually a pretty crappy environment, with people coughing and sneezing. And that was no fun even before COVID-19. Then you sit down in one of those uncomfortable chairs next to a pile of 10-year-old People magazines, and you're looking around and you're looking at the people that are there. Maybe it's an oncology clinic, and you're wondering about that guy over there does not look so good. Or I don't look so good. He looks better than me. And then you're dealing with that clipboard. You know that clipboard? 5 or 6 visits per month to get your infusions and your radiology and your everything else. That clipboard that asks you the same questions over and over again, shoved in your hands by an administrative assistant who's distracted by whatever they're distracted by. You have to listen to them chatting about their lives, right? But you listen to that background murmuring of everything's routine while you're experiencing your own sort of inward level of anxiety and distress. And in that environment, you become not the person you are, you become another patient in a queue. And then they take you back maybe 20 minutes late, maybe an hour and a half late, and they put you in a room without windows and some sliced in half diagram of a pregnant woman or whatever it is, or nose with whatever it is, and more crappy old magazines, and you sit there on the exam table waiting, listening to the murmurings of people going back and forth. And then your doctor comes into the room, and your doctor sits down and says how you're doing, and then turns like this to begin asking you the questions that manage their agenda. And that doctor, if they're wonderful, they bring themselves to the encounter. But if they're regular, if they're average, they can't afford to bring themselves to the counter because they're trying to do 3 or 4 visits with serial patients in an hour, and they're already running 30 minutes behind. And while you're managing your anxiety, they're managing their own, doing their point of care documentation. And it's only when they pause and stand up and reach for the doorknob that you actually are present to the thing that was most important to you. And then you're home 3, 4, 5, 6 hours later. Where we live, people are driving 3 hours, 2 hours to get to rural centers of care, and all in the interest of improving your quality of life. Right? If we can eliminate all that, and all you have to do is click on a link, and poof, your person's there, and they may be in a computer, but they're actually looking at you interactionally, relationally. This environment of care that's defined by this frame is a whole new world for the provision of care that allows a person to be sitting at home.
So right now, the New York Health and Hospitals, the largest public healthcare system in the country, just put out a call for any and all palliative care-minded clinician volunteers to have goals of care conversations with patients and their family. How does that strike you? Do you have thoughts on that?
Number one, I want you to forward me that notice. There's 2 things that are going to change as a result of COVID-19. One is already happened in like the blink of an eye.
Mm-hmm.
Telemedicine adoption and implementation and integration in healthcare delivery is never going back. And that genie is not going back in the bottle, and that toothpaste is not going back into the tube. So telemedicine has far exceeded its tipping point. Second thing, and I think it's actually even more important, honestly, is that people are going to recognize the importance of palliative care as an integrated part of healthcare delivery for seriously ill people, either ones that are approaching the end of their life or are simply confronted by their mortality. All the work that's been done by CAPC and our leadership and all the sector and industry leaders, all the great mentors that I've had over these last 25, 30 years has brought us right to the edge of that tipping point. This crisis will take us over that tipping point. And on the other end of COVID-19, the expectation that palliative care will be integrated in the care of very sick people is also toothpaste that's not going back into the tube.
Both on behalf of healthcare, thank you, but on behalf of our little corner of the world, thanks for being such a great teacher and collaborator. And thanks for taking some time out of your busy schedule to talk to us and share with others what you're learning and how it's going. Good luck and stay safe during all of this.
So thank you guys for figuring out what the hell artificial intelligence really means and data science, what it can do.
Sure.
So thank you for that. My pleasure.
All right. We'll talk soon. Stay safe, Michael.
Okay. Take care. Bye-bye.